All right, thank you to everybody for joining us today. We are recording today's meeting, so I want to make sure that that's known by all of the participants. It will be posted on beWellnm's website on the committee landing page for anybody who does wish to view it. We'll also be posting the slides and agenda that were presented as well. And so let me actually pull up that agenda now so that we can all view it together and make sure that there isn't anything that folks wanted to make sure that we covered today that wasn't included in the agenda that was sent out. Give me one moment.
Colin, this is David Shaw. I'm sorry I was a little late getting on.
Oh, thank you for joining, Chairman Shaw. Appreciate you being here. And I know you're dialed in today, so I have let folks know that we're recording the meeting in case you do want to come back to watch any of it. And Director Wishner as well wasn't able to join today, so we'll be sure to share that with her.
Thank you.
All right, so are folks able to see my screen?
Yes.
Okay, great. So thank you to everybody who's joined us today to learn about this committee's work on standardized plans. This committee is chaired by the Superintendent of Insurance, Russell Toll, who is actually out of the office. And so the superintendent didn't want to hold up the committee's important work, and he asked me to fill in for him today. He will be available for the remaining meetings that will occur for the rest of this year. So my name is Colin Bio. I'm the Director of Coverage, Affordability, and Expansion at the New Mexico Office of Superintendent of Insurance. I'm joined today by my colleague Sahar Hassanin, who has conducted extensive research on the topic of standardized plans, and she'll be able to provide the committee with some great information about her research on this topic. We do have new committee members on this committee. One is Director Jane Wishner, who just recently joined the board of directors. She isn't able to join today, but we do have another new director, Director Ann Sapon, who's new to the board as well. And I thought it'd be good to do a round of introductions of the committee members who are here today. So Director Keene, would you like to introduce yourself first?
Sure. I'm Nandini Keene. I'm Vice Chair of the Board of New Mexico Health Insurance, and I'm very pleased that we're doing this. I'm really looking forward to your presentation.
Thank you, Director Keene. And Director Shaw?
Good afternoon, everyone. Sorry I can't be there, but wanted to introduce myself, David Shaw, CEO at Norley Hospital District in Lovington, and also the chair of beWellnm.
Thank you for being here. And Director Sapon?
Hi, good afternoon. I'm Annie. I'm currently a member at the beWell board and previously was the Chief Operating Officer at True Health New Mexico and am currently a healthcare consultant. Thank you.
Great, we're so glad to have you on the committee, and I think your expertise will be very valuable for the work of this committee. So I think before we get started, I have the agenda pulled up here. I shared it with the committee yesterday, and I do want to note that there's one change on this agenda, that we've removed the review of 2023 plans to give ourselves a little bit more time for analysis, which we're hoping to be able to present to the committee at our next meeting on November 14th. And I'll just briefly go through. We have the introduction of committee members, the approval of the agenda we're looking at here, a review of key topics, including the basics of standardized plans, research done by the committee to date, the state out-of-pocket assistance program that is starting this year, committee priorities from 2021, and then some of the proposed plan designs that were produced through this committee's work last year. And then we'll open up for committee discussion, provide an opportunity for public comment, and then go over some of the next steps for the committee, which is really focused around getting public input on the plan designs, and if we do want to consider any sort of changes to what's been proposed based on the feedback we get and be able to analyze and assess that, we'll be able to do so over the coming months before any of these plan designs make their way to the full board of directors for approval. And then the information for the next committee meetings will be posted on the committee landing page. I will make sure before this meeting ends to put that link in the chat so that people have easy access to it. So of those board members that are on the call today, do you approve this agenda, or are there any changes that we need to make before moving forward?
I would move approval.
Great.
Yeah,
And did I hear a second?
Sure, I'll second it.
Okay, great. All right, so the agenda is approved, and I will now pull up some slides that what we wanted to do today was really try to provide some context for the work that the committee has done so far, how it's established priorities. Oh, and I'm sorry, did I miss something that you were saying, Director Keene?
No,
Oh, sorry.
I'm fine.
All right, so we wanted to provide some of the context, especially for new members and members of the public who have not listened in on previous meetings of the committee, so that you all know what work has been done by the committee, and then we can kind of move into receiving public comment and discussing what has been done so far. So I will just briefly go over some of what will be covered today. We're going to be reviewing the committee's work from 2021, present some information about our state out-of-pocket assistance program, review the proposed plan designs from last year, initiate our stakeholder feedback process for plan designs in 2024, and then discuss some of the upcoming meetings, objectives, and those opportunities for input. And I think one thing that I do want to note is that everything we'll be discussing today, of course, will not apply to the 2023 plan benefits year that we have coming up. The board of directors is required to approve any plan standardized plan designs in the January board meeting, the year before the plan year that's being discussed. So that would be January of 2023. The board would have to vote at that time to approve any plan designs. And so last year, the committee did meet to review what other states have done in this space, looked at research and developed priorities for standardized plans, and ultimately several income-based standardized plan designs were proposed, which is what we'll discuss today. The committee did decide to hold off on submitting those plans to the board of directors during that initial year, or this initial year of implementation of the Healthcare Affordability Fund programs, and to provide this extra time for stakeholders to and the public to provide input on what has been proposed. And so that's what we'll be doing over the series of meetings that we're kicking off today. So we did want to start by actually just giving a simple explanation of what standardized plan designs are and what the purpose of them is. So standardized health plans are plans that are offered by all insurers in a market that have the same out-of-pocket costs or cost-sharing design. So that would be all of the carriers that are offering coverage in the marketplace of beWellnm New Mexico would offer a plan that has the same deductibles, out-of-pocket maximum, and then copay design and coinsurance design structure that is approved by the board of directors. There is a trend in marketplaces for plan standardization. There are 8 states and Washington, D.C. that are going to be requiring standardized plans in 2023. The committee reviewed those last year. And we do have a new state since then. Our neighbors in Colorado will be offering standardized plans for the first time this year. And the New Mexico legislature did authorize the board of beWellnm New Mexico to establish no more than 3 standardized health plans for each of the 3 levels of coverage. And that would be within each of the metal levels of bronze, silver, and gold plans. What was not authorized in that legislation was only offering standardized plans, so health insurers will still have that opportunity to offer their own plan designs, but the expectation here is that they would also be offering this specific plan design that is approved by the beWellnm Board of Directors. So to look at some of the states that have started to initiate plan standardization, you can see here that California, Oregon, Washington, New York, Massachusetts, Vermont, Maine. Sahar, can you help me out with what state this is? That's
there's Connecticut and
that's right,
there's
Connecticut, and then
Maryland
Maryland.
and District of Columbia.
Okay, that's right, and DC also. And you can see that there's different approaches here. Something that's not spelled out here, but we do have 2 states, California and Massachusetts, that only allow standardized plans to be sold. A lot of other states will offer both non-standardized and standardized plans. And then you can see here that there is 1 state that only limits how much plan deductibles can be, but doesn't require specific dollar amounts for other cost sharing forms. So that's one of the states that I believe that's Maryland has initiated that. So it is important, I think, to review why standardized plans are something that could be beneficial to consumers. So standardized plans can give consumers the opportunity to compare plans side by side without becoming overwhelmed by the vast array of differences in the cost-sharing design. So certainly something that we've heard at the Office of Superintendent of Insurance. And I think that if you just talk to anybody about picking a plan, even on the marketplace that has a lot of helpful tools for making choices, it can be difficult to look at all of the differences between the plans that are offered, and it can be a pretty overwhelming experience for people. So that's one basic positive benefit, is that you can have that apples to apples plan comparison where people don't have to worry about the plan design as much and can actually compare the options based on some other factors. The other thing is that standardized plans can be designed in a way to meet specific objectives. So one objective that this committee was very focused on last year was improving cost predictability for consumers. And one thing that came up pretty consistently were concerns about coinsurance. Now, coinsurance is when an insurer charges consumers for a percentage of the cost of a covered service. So if there was a 10% coinsurance rate and the bill for a service was $5,000, the patient's share of what is owed to a provider would be $500. And the problem is that we don't often know how much that final bill is actually going to be until after that service is provided. And so that makes it really difficult for patients to know how much they're going to be charged. And I think we've all heard the statistic by now that nearly half of Americans in a survey conducted this year said they wouldn't be able to rely on their own cash savings to pay for a $400 emergency expense. So if you're not sure how much something is going to cost and you're facing that sort of economic reality, which is certainly the case here in New Mexico, it can be really hard to make that decision to seek those services. And we see just this basic design of coinsurance being that barrier to people getting the care that they need. And sure enough, some of our research last year did show this to be the case. Copays are sort of the other model here, where you would pay a fixed amount for the services that you use within these different service categories. And that has been shown to be a more straightforward way to charge patients for services and offer better cost predictability. Right now in our marketplace, we have a mix of those two things. Some plans do tend to have more of a copay-based structure for their cost-sharing design. Others tend to be more reliant on coinsurance. For the most part, we see a blend of the two, and it varies by service. So another way that standardizing benefits could be helpful to consumers is by minimizing the number of services that are covered by the deductible and also setting deductibles and out-of-pocket maximums at a reasonable level. Some states have set copays at low levels for high-value services like primary care and generic medications. So those are just a few ways that standardization can help patients. Now, but we do have to keep in mind that there could be some potential premium differentials between standardized plans and plans that are designed to have much lower premiums. And that's a trade-off that we'll want to keep in mind as a committee. The other thing to keep in mind is that when we lower costs in one services, typically you have to make adjustments in other areas of plan design. And so that's something that we'll talk about a little bit later and how the committee weighed that last year. And we'll talk a little bit about the guardrails that are used to keep overall out-of-pocket costs in check at the federal level. So now I had mentioned that the committee requested research into the topic of plan design last year and the relationship to access to services. So I'm going to turn it over to my colleague Sahar to review the findings from last year. And Sahar, you just let me know when you need me to change the slides.
Okay, thanks, Colin. Good afternoon. This is just like a selection of some of the research that guided many of the decisions that went into choosing or resorting to some elements of standardized plans in several states. I'm not going over everything that I looked at, just the studies and the research that has some quantification of the impact that we're talking about. So only 4 pieces of work, I'm going to highlight the results from them because they give us a sense of magnitude in various situations. The first study that basically conducted a questionnaire of about 8,000 members of a patient organization, and they looked at the type of cost sharing that the individuals face, including the rate, the type, whether it's a copayment or a coinsurance, annual caps on cost sharing, which is the maximum out of pocket, and all those plan parameters and how those impacted patients' behavior when they had a referral either for filling a prescription, for having a diagnostic test, or going for a specialist visit. The population of the study, some of them indicated that they chose not to go further and follow the recommendation of the physician because of some uncertainty about the cost that they're going to incur. And others, they had questions for others who chose to do to basically utilize the referral. And for those, one important issue, again, related to cost is the time of payment, whether the payment is at the time of service or is it billed later to the patient. And that made a huge difference for those who chose to go ahead and use the referral. For the population who chose not to go, for the population who chose to go without the service, the important results and the magnitude is really, really significant. And this is something that we want to highlight for this piece of research is using a micro simulation model, they looked at those who chose not to seek the service, and if there was a copay instead of a co-insurance, they estimated that 80% of the people who got the referral would have filled the prescription. So this is like a huge response to the choice of the type of payment that was included and presented to them. That percentage is 73% would have done the diagnostic tests, and 75% of those who chose not to go ahead and complete the treatment would have 75% who were recommended to see a specialist, they chose not to do it. So these numbers are huge in terms of how the choice of the cost sharing design impacts further treatment and further access to healthcare that individuals choose to go without. So this is one important piece of research that we're taking into consideration when looking at the magnitude of such choice of policies. The next slide, please, Scott. This was another study that was basically looking at the change in the cost, and it was looking at prescription drug benefit program in Medicare, and they were looking at magnitudes. So they were looking at this, like a 33% increase in out-of-pocket. How does that affect filling the prescription and drug consumption? And in turn, how does that create problems with percentage change in mortality? The most important result in my mind in this result is the very last bullet in that slide, which is an increase in the price of one drug. Sometimes leads patients to just forego all the drug filling requirements. They're just so overwhelmed by how they need to make complex choices, whether they buy this drug or the other one and all that stuff. And they decide that, this is just like too complicated, and they decide to go without any drug utilization, with all the complications that may have for people who have multiple health issues that they need to deal with. Next slide, please, Colin. This was also a very interesting study that was conducted with employees of a large US firm. Obviously, it was not identified by name, but they looked at the situation where the employees were faced with a lot of choices that they had to make in terms of what kind of plans they choose, whether these are the best plans for them, and so on and so forth. And they calculated, and they were looking at plans that, from a financial perspective, they were better for the individuals. And the results, which again are very telling, is that a lot of employees, because of the complexity of the choices that they had to make, they ended up choosing choices that were not economically beneficial for them. That, again, quantifying the results, they estimated that employees could have saved 2% of their mean employee annual income, and they could have saved 42% of annual employee premiums had they chosen the right financially sound option from the menu of options that they had. As can be expected, employees in lower salary bands were disproportionately likely to choose financially dominated plans. Also, female employees, older employees, and employees with chronic health conditions were all significantly more likely to select less than optimal plans. So basically, the conclusion from that research is sometimes too many choices for individuals, especially when the choices involve like complicated parameters and complicated pluses and minuses and so on and so forth, that does not produce the ultimate beneficial choice for the person facing too many choices. Next slide. Yes, please. Thank you, Colin. This was a stakeholders type study, so it was not focused on patients and it was not focused on utilization per se. It was just gauging the responses and the attitudes of different stakeholders. And we have like quotations from that study that represent, the apples to apples comparison that Colin mentioned, and taking as much mystery out of the game as possible. That was a quote. It's about consumer understanding their choices, another quote. And then the last three comments, these were in reference to how the dynamics of the stakeholders discussions were. So one stakeholder expressed that insurers were really interested in having non-standardized plans along standardized plans. So they were not too excited about having only standardized plans to be offered. Another state official said that in general, the companies are in the best position to design the plan benefits and the cost sharing, because they can innovate and react and change. But then there were all sorts of mixed quotations in this study. But it was really interesting to see that, there was a healthy discussion about, if we want to do the standardized plans, what are the best approaches of doing them, whether they are voluntary or mandatory, and so on and so forth. So that was something that would probably be subject to discussion in the context of the proposed standardized plans for New Mexico. So that ends the literature for the standardized plans, and Colin, you can go with the rest of the presentation.
Great, thanks, Sahar. So a few more things to cover before we get into some discussion. As folks might know, the legislature passed a bill in 2021 to establish a healthcare affordability fund, the funds of which can be used to lower costs for both premiums and cost sharing, out-of-pocket costs for plans on beWell New Mexico. And we are rolling out those programs starting in 2023. Very excited about it, but it does add a new dimension into our considerations for plan standardization. We did, as we were looking at options last year, consider some of these basic parameters in the plans that were proposed. But I did want to go over some of the basics about how these new subsidy programs work. So the first is that individuals and families up to 300% of the federal poverty level who qualify for federal premium tax credits on beWell New Mexico are going to qualify for our new out-of-pocket assistance programs. You might hear us call this SOPA, State Out-of-Pocket Assistance. And what this does is it reduces the deductibles, maximum out-of-pocket limits, co-pays, and co-insurance for certain plans. So this year, OSI approved plan designs that were submitted by all of the carriers that are offering coverage on the marketplace this year. So those designs are unique to each carrier. They are not standardized in any way. But they did have to meet certain thresholds that I'll talk about in a moment that reduce the cost for consumers. This program is going to start on January 1st of 2023. And people are actually going to be seeing these updated lower cost plans during open enrollment period, which starts on November 1st. So in order to benefit from SOPA, consumers have to select what we're calling a turquoise plan. And these are the plans that have those extra savings built into them. They have some state funding provided to lower those out-of-pocket expenses. And when consumers shop for plans this year, they're going to see a marker if they qualify for turquoise plans of which plans are turquoise. And we appreciate all the great work that beWellnm and their technology vendor did to make it clear which of these plans are going to have these enhanced out-of-pocket savings. So there are 4 levels of turquoise plans based on household income. And enrollees under 200% of the poverty level have to pick a silver plan to get SOPA. And then enrollees between 200 and 300% of the poverty level have to pick a gold plan to get SOPA. But to make that choice simpler for consumers, these plans are going to be labeled as turquoise plans. And so when we talk about income-based versions of standardized plans, these are going to be turquoise plans that have the same out-of-pocket costs. And so we've really built these in large part on how federal cost sharing reductions are developed. And there's a concept known as actuarial value, which the committee has reviewed in detail last year, but that basically explains the average costs for covered benefits that a plan will cover. And so silver plans typically will have a 70% actuarial value. Gold plans have an 80% actuarial value. Ultimately, that winds up meaning that the cost sharing structure for a silver plan is going to expose people to more out-of-pocket costs. They'll have typically higher deductibles, max out-of-pockets, co-insurance, and copays than a gold plan. And then the variants that are submitted and approved from each of the carriers have to meet other actuarial value standards. And you can see in the first turquoise level, that's for people up to 150% of the poverty level. The actuarial value for those plans is 99%, so very minimal out-of-pocket costs. For the next group between 100 and 150% of the federal poverty level, the actuarial value is 95%. And then you can see that it continues to step down as we get higher up the income scale, with the idea that as you do make more money, you are better able to deal with additional out-of-pocket expenses. But that lower income folks really are more likely to delay care when costs are too exorbitant. And so you can see for that third group, a 90% actuarial value plan, and then an 85% actuarial value plan. Now, that all is a little bit in the weeds, but it is an important concept when we're thinking about the plans that we are designing and these targets that we need to be able to hit. So I know that is a lot of information, but it is our starting point for our standard plan designs. And what we're showing here is based on the deliberations of the committee during its meetings last year. And I'm going to point out some of the features about these plans and how they incorporate the priorities that you see from last year. And before I get into that, just go over one of the key ones, of course, was providing apples to apples plan comparisons. That's kind of a basic standard for standardized plans. Improving that cost of predictability by basing our design on copays instead of coinsurance for the reasons that we discussed before. Categorizing copay levels by lower, medium, and higher amounts, with those higher value services like primary care and generic medications having the lowest out-of-pocket costs. And then minimizing deductibles and out-of-pocket maximum limits to the greatest extent possible, minimizing the number of services subject to a deductible. And then I think through some really good discussions that the committee had about how in rural areas, a lot of times hospitals are a key place where people get services and they may have limited access to other types of providers. So initially we had some higher costs for hospital visits, but recognizing the reality in some of the rural areas of the state, there was an emphasis put on trying to minimize those costs or make them as reasonable as possible to make sure that people don't get priced out of care in those settings in those rural areas. So that was one thing that was built into what we'll look at next. And then lower out-of-pocket costs for specialty medications, which typically are used to treat complex chronic conditions like MS, cancer, rheumatoid arthritis. And Director Teresa Gomez, who is no longer on the board of directors, but who was a member of this committee and is a cancer survivor, really, I think, did a great job of advocating to this committee about the importance of making those specialty medications more easily accessible to people who need them. And in a lot of cases, these are life-saving medications that people really, really need. And the case was made that we really should try not to go down the road of making the costs of these medications some of the most expensive for patients, which tends to be the case with a lot of insurance cost-sharing design. And then finally, focusing on income-based out-of-pocket designs as part of that new state out-of-pocket assistance program that I just described. So here we've got a lot of information, and it can be a lot to take in all at once, but we did want to go through the basics of these income-based standard plan designs. And so you can see that we have a design for each of the income levels that I just described. And I'm going to go over just kind of more at a structural level what's happening with the proposed designs from last year. So the first thing is to point out the cost predictability by using only copays. So in the services that we are looking at here, you can see that we don't have any percentages in here. These are all fixed dollar amounts that we're looking at for all of these income-based standardized plan designs. So that's one thing to keep in mind. And then you can see that we've categorized the copay levels by the lower, medium, and higher amounts. So in the lower amounts, you can see we've got the preventive care, screening, immunization already does have to be free of charge under the Affordable Care Act. Mental health, behavioral health, substance use, and outpatient services, those actually are also required to be covered free of charge under a New Mexico state law. And then you can see the other key service here is primary care visits to treat injury or illness. And you can see that we have a $0 copay for the lowest income bracket, $3 for the next, $5 for the next, 10 for the one after that. So you can see how that steps up a little bit, but we've really tried to keep it in the lower cost category here. And then we have our mid copay category services that do tend to be things that are more expensive services, but that also, we want to encourage people to use primary care oftentimes before seeking these other services, if it is something that can be handled in that setting. And so the cost for these a little bit more. You can see for the lowest income group, all these services that are covered here, which include specialist visits, imaging, speech therapy, occupational and physical therapy, laboratory outpatient and professional services, x-rays and diagnostic imaging, skilled nursing facility, and urgent care facilities are going to have the following copays. For the lowest income group, it'll be $3. For the second lowest income group, just $10 for these services, $20 for the third income group, and then $30 for the fourth income group. And then we move into the higher copay medical service categories, where we have outpatient facility fees, outpatient surgery and physician and surgical services, emergency room services, and inpatient hospital services. And you can see again, the cost scale up a bit here within each income bracket. And then when we get down to prescription medications, having generics really line up with that low copay medical service category. Preferred brand then being a little bit more than that. And then we have non-preferred brand name drugs, which do get up into higher copay amounts, you can see here, and are also subject to the deductible. And then specialty drugs, which typically this isn't the case, but because of the discussions that this committee had, for the lowest income group, we have that at a $10 copay to fill a prescription in that category. $25 for the preferred specialty drugs in the next category of income, $50 for the third income category, and then keeping that at $50 for the following income category. So you can see the overall organization of these is also designed to give people a little bit more a way to sort of organize these services in their own heads about how much these services are going to cost when they use them. The other thing that you can see in here is that we've tried to minimize to the greatest extent possible the maximum out of pocket and deductible. So for the lowest income group, a $0 deductible, $200 out of pocket maximum. For the next income group, a $50 deductible for an individual, maybe $100 for a family, and then a $1,500 maximum out of pocket for an individual. In the next income group, a deductible of $750 with an out-of-pocket maximum of $2,000. And then in the highest income category, a $1,500 deductible with a $3,000 out-of-pocket maximum. Now, of course, these are reduced in many circumstances from what would be available if you were just getting the version of these of a plan on the exchange that doesn't have these out-of-pocket cost savings. And then also note that most of the services here are not subject to the deductible. We've really only focused on 3 service categories here: emergency room services, inpatient hospital services, and non-preferred brand name drugs. So that was another thing that the committee was focused on, was trying to minimize the number of services subject to the deductible. I think did a good job of that with this. And then again, looking at the specialty medications and hospital services, there was an earlier proposal of these that had these at higher copayment amounts. And I believe the specialty drugs were also at one point subject to the deductible. So that got altered after the committee made those recommendations. And so this is what the committee ultimately arrived at last year. As I noted at the top, ultimately the committee decided not to move forward with these for this upcoming plan year because we wanted a little bit more time to really give ourselves the opportunity to implement some of the healthcare affordability fund programs. And given the level of effort there, wanting to have some more time to analyze this, and then also to incorporate feedback from stakeholders. So what the superintendent wanted me to really emphasize to those listening in today is that we need to hear from the public and stakeholders about what is being proposed here, how it can be approved to meet those objectives of the committee and the legislature. And we do have an actuarial consultant called Wakely Consulting that will be on hand in future meetings, who can help our committee to evaluate the feedback that we receive and incorporate updates into updated plan designs as we receive that feedback, both from the committee and also from the public. So with all that being said, I think now would be a good time for us to open up for discussion from the committee and then move on to public comments and display some information about next steps and agree upon how we're going to be gathering information from stakeholders.
And this is Annie Sapon, and I just have a quick question. Last year, did the committee have a discussion regarding, I mean, copays are a wonderful thing, but it also puts the consumer in a place of not understanding the cost of healthcare. And those of us that are in that space realize that, you know, a primary care visit is not $0 or a specialty care visit is not $3. And so, you know, I think that a lot of, when you see a lot of the language of the Affordable Care Act, it's like really trying to educate consumers on healthcare. And so did they have some discussions about, you know, not just having our consumers think that the cost of the healthcare is only $3 and that truly what the cost is, that the state is paying for that, as well as the insurance carriers, just to begin kind of raising that level of healthcare acumen.
I think I can offer what some of my takeaways from last year were, but I would definitely welcome them from the other members who were present. But I think actually that the cost predictability aspects tended to have a little bit more weight with the committee last year, and I think that might kind of be in tension with that the underlying cost of care piece that you're talking about with coinsurance. And I don't know if there's a really easy way to strike that balance, but Director Keene or Director Shaw, is there anything that you wanted to weigh in on that, or anything that I may have misconstrued from last year?
Do you want to go, David? And
Yeah, Colin and Director Sapon, thank you for bringing that up. I think that's a very good point and something that we sometimes lose sight of. There is absolutely a cost to healthcare, and we really didn't discuss that in detail last year. And I agree with Colin. I'm not sure how you strike that balance with the standard plans.
yeah, I think that, sorry, Annie. I think the committee last year was just looking at how do we make sure that the cost of receiving healthcare, even if you take a look at the research that Sahara has done, you know, how do you not deter patients from seeking service or taking their medications? Or, you know, we were focused on how to not have cost to be a deterrent to healthcare. But I think your issue about somehow making sure people realize that that doesn't mean the cost is free. I'm not quite sure how you get that across to someone who is, you know, just trying to manage his healthcare crisis at some point. But
Yeah.
if you have ideas, if you've done that, Annie, in your work, we could probably use your experience here.
Yeah, I mean, there are obviously ways to go about it. I'm just was curious because, you know, inevitably in the cycle of healthcare, and I've been in it too long. But the reality is that funding subsidies dry up, and we have our consumers who don't all of a sudden think there's this huge increase in healthcare, and it's not actually the increase in healthcare, but rather the subsidies that were there supporting a lower price point. And so how do we begin, you know, to really look at that holistically so that you can have a longevity and success in the plans?
That's a good point. And Director Sapon, I think maybe my bias last year is the fact that at least in my specific situation in running a hospital, the situation is that we see a lot of people who don't have insurance, who don't access the system until it's too late. You know, they're in the emergency room and the situation is a crisis and it's out of control, and there's a lot of cost to the system, and the hospital ends up absorbing that because they have no insurance through charity care and things like that. But I wonder, and I'm just thinking out loud, I wonder, Colin, maybe you can help me with this, but you know, when these individuals sign up for these plans, is there any way to highlight in their plan documents or in their bills that they receive how much of the cost of their insurance is subsidized by the state? You know, that way it would kind of highlight to them that, you know, this is not free care and that somebody's paying for it. To Ann's point.
Yeah, you know, I think at least on the premium side, when somebody goes through the beWellnm application, they're both going to see the federal premium tax credits that they qualify for and how much that's reducing their costs. And then for the additional state funds that are going to be applied, that will be shown as well. So on the premium side, I think that is the case. I think when they're signing up, it's difficult to provide that information about how much is being saved on the out-of-pocket side. I think where they're more likely to see that is when they get an explanation of benefits, and that has information about the total cost of services, and then how much they will owe would come through a bill that would come from their provider for the services. So I think that is certainly one way that people have access to that information now and understand that there not only are programs like this that are helping to lower those costs, but also that their insurer is bearing some of that cost as well. Director Sapan, I think one thing that one way maybe we were thinking about it a little bit differently, but that we were trying to get at what you're describing here is having these different categories of low, mid, and higher copay services. And I wonder if maybe we could recategorize certain things here based on that underlying cost, so that even if somebody isn't being exposed to that full amount, at least the relative amounts here in some ways will be more aligned with how much a typical service would cost within any of these given categories. Do you think that might be where we could find a way to achieve what you're raising here?
Yeah, I mean, I think there's several opportunities and approaches, and I guess my point in bringing it up is I think there's value in having the conversation as we proceed in this discussion. Thank you, Colin.
Certainly, thanks for raising that. I think that's a good point for us to think about.
I think somebody has their hand raised, Colin.
Oh, sorry, I didn't see. Oh, Paige, my colleague Paige Duhamel. Thanks for joining today, Paige.
And again, I really kind of wanted to push back on this because I feel like I've said it a lot over the years. But I mean, only something like 20% of healthcare. If we're trying to make consumers aware of the cost of healthcare, I would say most consumers are generally aware of the cost of healthcare, because a lot of consumers have been uninsured and had to pay out of their pocket at some point in their life. And so what are we trying to accomplish if we really are sort of trying to highlight the cost of healthcare? And if we're trying to get people to shop for their healthcare, only 20% of that is really shoppable. And again, those costs aren't always transparent to consumers. And, I do think that the point that the Sahar made in her initial presentation about deferred care is really important. I mean, a lot of people, regardless of whether or not they fall within this 300% of the federal poverty level or not, defer care because it is expensive. Like, that is just kind of unquestionable. I mean, personally, I got surgery last year only because my student loans were deferred. I mean, I can't afford to get healthcare that I need, and I'm a state employee, So I don't want to address a problem that there's not much that these people can do anything about.
And I think, Paige, thank you for your feedback. I mean, I can appreciate that. I guess my concern lies with, I mean, I know you think that people, they realize because they've been uninsured and they've not accessed healthcare. I mean, from my perspective and my lens of where I've been, I mean, I see where people say, oh, well, it's only, $10 for me to have an MRI, right? And so I'd like you to do an MRI on my knee, even though, it may not be necessary, but it's affordable. So it's really, I mean, we do have limited resources in New Mexico, right? And so how do we also make sure that we're not inundating providers and that people are truly using appropriate care? And I'm not saying that.
And I mean, the check on that is always the medical necessity review, right? You guys put everything through prior authorization. It's not, I mean, I'm reviewing that now with my team. I mean, every year I see a growing list of prior authorization requirements from the insurance companies, and you guys, kick stuff back all the time if it doesn't meet medical necessity standards. So I think I'm just trying to caution against shifting the burden onto consumers for making those decisions when they're already, as Sahar pointed out, really making decisions about what they can afford for cost of care.
I don't think it's the burden, it's just the education in general. And if this isn't the appropriate venue to leverage that opportunity, great. But I just think it is really really critical that people's acumen relative to healthcare costs rises in our community.
Okay, thanks. And Debbie, I saw that you came back on screen during that discussion. I don't know if that's a hand raising or if you were just coming back.
Well, I was just coming back, but well, I was going to raise my hand, but Paige kind of said it. And burden or not, I think the goal of this, and maybe it is education, and we do need to do that education. But part of that education is if people get the right care at the right time in the right place, the overall cost of healthcare will go down because they're healthier. So the point is keeping them healthier and not making it a burden to access. And the rising cost of healthcare and how expensive it is incumbent upon carriers and legislators and so forth in addressing the systemic issues that we can. But I don't want to lose sight of we need people to access the care that they need and not defer it. So I like the 3-step, things that are we really don't want them to skip on. We have almost no copay, and then it steps up a little bit. So I really like this design that you've done, and I think it moves it towards that goal of making it as affordable as possible for people to get the care that they need. Because I appreciate that there's people that see it on TV or they want everything they can get. Paige is right to a certain degree that is stopped with medical necessity, but I think far more often people don't access the care that they need because of the cost. So thank you.
Thanks for that perspective, Debbie. And I see that Pamela Blackwell has her hand up. Hi, Pamela.
Hey, Colin. Thanks so much for having this webinar. A slightly different perspective on that, on the education piece is it's also an opportunity to share with voters, with taxpayers, what their taxpayer dollars are going towards and allow for, and they allow for better health. So if you can show that price differential in some way, you're like, hey, thank you so much for coming to get this primary care. This can save you down the road this much money. And guess what? You'll also be a healthier person for family and friends down the road. I feel like it's almost a transparency and, thank you taxpayers, legislators, et cetera, for doing what you are able to bring better health to New Mexicans. So just a different angle on that education piece.
Great, thank you, Pamela. All right, any other discussion from the committee about anything that we've gone over today or anything you think we didn't cover that you think should be?
So, Colin, I just wanted to make sure I understood where we're going with this. I think you touched on it, but forgive me for asking you to repeat it or clarify it for me. So, at the time that this is issued on the exchange, what you're saying is that, or at least what the material I read that you distributed said, is that these plans will be told turquoise 1, 2, 3, 4, but any insurance plan can.
Oh shit! This looks important.
All insurance plans required to submit these, or is it going to be up to each insurance company to decide whether they want to participate?
So it would be a requirement that the board of directors, or typically how the standardized plans work, is that it would be a requirement that all of the insurers offering coverage on the exchange would be required to adopt plans that have the standardized cost sharing amounts. And then that they would have the opportunity to continue to offer other plan designs as they see fit.
Mm-hmm. Thank you.
And I think I noted, we have to basically have these plan designs approved by the board of directors by the January board meeting. So this upcoming January board meeting, those would get approved. And then let's see, basically it wouldn't be until the 2024 plan year that they would actually be in effect. And then I think to answer to one of your other points too, so the insurers are gonna be able to continue to offer their plan designs for the 1, 2, 3, 4 turquoise plans. But we would probably want to have some sort of other differentiator that helps people to see which plans among these turquoise plans are the ones that are standardized. And so we'd probably want to have some sort of marker of, beWellnm apples to apples plans or something along those lines, maybe Chili's to Chili's.
Chili's to Chili's.
Very good.
You're funny.
Thanks.
So if there isn't additional discussion on anything that's been presented so far, I think would like to provide some time for some public comment. But before we get to that, did want to go over kind of what our next steps would look like. And knowing that we probably need to allow a little bit of flexibility here because we want to provide the opportunity for input, the opportunity to digest that information and try to incorporate some of it into plan designs if the committee is interested in seeing how some of the input we get might impact the plan design. So our next meeting is scheduled for November 14th from 11:30 a.m. to 12:30 p.m. What we're proposing, and definitely if the committee thinks we need more time for this, but what I was thinking that would be a good idea is November 7th, allowing folks to provide written comment or proposed changes up until that date. That gives us a little bit of time to kind of consolidate that information and put it into a format that can be presented to the committee for consideration. And then during that meeting, review those comments, the proposed changes, receive additional public comment after the committee has had time to discuss those, and then give the committee the opportunity then to decide whether it wants to take a look at some updates to those plan designs. Then that following meeting, we could come back with those. We could provide some additional opportunity for written comments based on the discussion that's had that day. Take a look at those updated plan designs, receive additional public comment, and then determine whether we do need to come together again in January to make any more decisions, or whether we're ready to actually, as a committee, adopt recommendations to be made at that January board meeting, and essentially allow additional comments to be made by November 28th before that December committee, so that we have a little bit of time again to digest some of the information that we received so it can be presented at that next meeting.
Could you make these available to us on the website, to listeners?
Absolutely. So I'll be sending these all out to the committee after this meeting, and then it will be posted. And why don't I actually put the committee website or the landing page on beWell in the chat so that everybody has access to that. That's where we'll also be posting updates and materials. So that'll be a good page to keep bookmarked. So unless there's any additional comment on that, I think we can then open up to public comment if there's anything that folks who are on today would like the committee to know before the next time we all come together. I see Jamie Sawyer has her hand up.
Hi, Colin, and thank you to you and the committee for all this information. It's extremely valuable and helpful to move in this direction for New Mexicans. I just would like to make a public comment in respect to the beWellnm exchange that we really need to stress the importance of the approval of the designs in the first quarter of next year to ensure that we have ample time for building our business requirements and testing on the technology side. So we definitely just want, that out there, the awareness around that importance to test and ensure that we have everything accurate on that side so consumers are aware of what options are available for them.
Thanks, Jamie. That's a really important point, and I think we got some good feedback on that before this was incorporated into the plan of operations. And I believe that plan of operations actually requires the board of directors to approve during that board meeting. So that is an important date for the exchange and for our carriers that we regulate at OSI, so that they have ample time to incorporate these plan designs into their plan filings. So thanks for raising that.
Thank you.
Any other comments for folks who have joined us today? All right, quiet group today. Well, we're looking forward to getting that feedback as you see here. If you do have any written comments, and I think particularly about the proposed plans that you see on this slide, I think this is a good starting point since it's based on a lot of the work that the committee did last year, and trying to adapt plan design specifically to the priorities that were established. So we'll be looking forward to getting those. I think if the committee is okay with it, we can stick to these dates of November 7th for the first round and November 28th for the second. Is that okay with members of the committee, Director Shaw, Director Keenan, Director Sapon?
Good with me. Just David.
So with me, yeah.
Okay, great.
Well, this is Annie.
Oh, sorry, Annie, I didn't hear what you said.
I said that works for me as well. They work for me as well.
Great. So I will make sure that those get posted, and when we have the final dates set for the year, we'll add those to the website as well. So thanks everyone for taking the time. Keep an eye on that landing page because we'll have a lot of this information posted as well as the video from today. So we appreciate the good discussion and the thoughtful comments, and we look forward to the next meeting. Thank you, everyone.
Thanks, Colin.
Take care.
Thank you.
Thank you, Colin.
Thank